Hey all, welcome back to the Real Life Pharmacology podcast. I am your host, pharmacist Eric Christensen, and I thank you so much for listening. As always, go check out reallifepharmacology.com. Go check out our free 31-page PDF on the top 200 drugs. A great little resource if you're preparing for, some sort of board exam, or if you just want a refresher, if you've been in clinical practice for a while and want an update on the top 200 drugs and kind of their common clinical quirks and pearls. Definitely go check that out at reallifepharmacology.com. Absolutely free to you, simply for subscribing. All right, so let's get into the drug of the day today, and that is hydrochlorothiazide. So this medication is classified as a thiazide diuretic. If you've spent any time in medicine working with patients, you've likely seen it. I will say it's probably fallen a little more out of favor over time here, but certainly with all the combinations of blood pressure medications, you still see hydrochlorothiazide quite a bit. So by itself, brand name is Microzide, hydrodiural. Can't say I see those very often. Most often what you're going to see in clinical practice is HCTZ, an abbreviation, which ISMP and for risk of medication errors and things like that. We are supposed to kind of go away from abbreviations. However, it is real life, and you certainly do see it. I have seen errors be reported from using the abbreviation HCT. That could be confused with something like hydrocortisone, for example. So again, be really, really careful with those abbreviations, but HCTZ has typically been pretty standard for hydrochlorothiazide. Uses, blood pressure, probably being the number one use there. I have seen it occasionally used for some milder edema, and potentially even added on in heart failure situations on top of a loop diuretic. More often I see Metallozone, but again, very rare cases I have seen it. But again, you're going to see it more often for blood pressure. Mechanistically, it blocks sodium reabsorption in the distal tubules in the kidney. And ultimately, by blocking that sodium reabsorption, we're going to send out water with that, and potassium and hydrogen ions can go as well. So that's all going to go obviously out into the bladder, and then obviously peed out by the patient. So from a adverse effect profile, we can imagine that sending more fluid to the bladder, we're going to end up with frequent urination. So if you see thiazide diuretic or a drug like hydrochlorothiazide dosed at night, be careful with that, and be sure to assess your patients and make sure they aren't having to get up all night to go to the bathroom. So don't be mean to your patients. This medication is typically dosed earlier in the day, and most often you're going to see it dosed in the morning there. So mechanistically also, loss of sodium, loss of potassium, loss of magnesium, those blood levels can all be reduced. And, how profound that is obviously is going to depend upon the dose you're using, as well as maybe other drugs that the medication's being used with. But it goes to show that it's important to monitor electrolytes with the use of hydrochlorothiazide. And particularly if that risk goes up as we use other medications that lower some of those electrolytes as well. Dehydration, risk, kidney function monitoring, that's going to be important as well. So monitoring creatinine, looking at GFR over time, making sure that we aren't inducing an acute renal failure situation, that's critical. Elevations in uric acid can happen, so keep that in mind in our gout patients for sure. And then interestingly, loop diuretics will expel, so a drug like furosemide will expel calcium with other electrolytes. However, hydrochlorothiazide, the way it works mechanistically, will actually help the body retain calcium. So hypercalcemia can be a potential issue with hydrochlorothiazide. Now, I will say I haven't seen it, particularly at lower dosages of hydrochlorothiazide and dosages that are most often used in blood pressure management. But there are certain situations where we may be at a little higher risk for hypercalcemia, and I'll talk about that in drug interactions. Hydrochlorothiazide does contain a sulfa group. So if a patient has a sulfa allergy listed, we should at least look at it and review it and inquire with the patient what exactly happened and what drug it actually was that caused the allergic reaction. And then, of course, you're going to want to get info on what the reaction was. So, for instance, if they had a severe life-threatening allergic reaction to a sulfa antibiotic, for example, that might be a situation where you're a little bit more cautious about using hydrochlorothiazide. But there is some evidence coming out now that maybe it is okay to use hydrochlorothiazide. So I tread lightly and obviously be cautious as much as you can. But that cross-reactivity risk is still a little bit controversial as far as that goes. So hopefully we'll get more and more evidence to say 100% that it's totally safe to give that versus not give it. But definitely be sure to kind of check the literature, and if you see that potential reaction or alert flag up on your computer systems and things like that, definitely don't hesitate to dig into it and make sure we're doing the right thing. Now, if somebody's got a sulfa allergy listed and they had GI upset from Bactrim, for example, I mean, obviously I'm probably not real concerned about using hydrochlorothiazide in that case. But if they had a crazy severe life-threatening reaction, that's a little bit more concerning, and you should definitely pause and take a look at the literature and see what other options exist as well. Elevations in blood sugar, I don't generally think it's going to be clinically significant, particularly at lower doses of hydrochlorothiazide. But it is something to think about if your diabetes patient loses control or something like that of their blood sugars and hydrochlorothiazide was recently started. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for pharmacist board certification study material like NAPLEX, BCPS, BCACP, BCGP, or BCMTMS, definitely go check out meded101.com/store. Your support there helps keep this podcast free for all to benefit from. In addition, if you're not a pharmacist, remember we also have tons of other resources, books on drug interactions, case studies, case scenarios, geriatrics, recent book on polypharmacy. All those links to Amazon books, Audible books, are going to be at meded101.com/store. If you've never tried an Audible book, I'd encourage you to do so. And we've got the links to the Audible books at meded101.com/store. And if you've never tried Audible, you can get your first book for free. So that is a unique perk with trying out Audible. And you can get 6, 8, 10-hour book, depending upon what you're looking at, for absolutely free. At audible.com. So again, links to all those Audible books and paperback books, ebooks, meded101.com/store. All right, finishing up on drug interactions. Hydrochlorothiazide can lower blood pressure, so any medication that can reduce blood pressure could have additive effects. So you're thinking of all your standard blood pressure medications, but in addition, there are some that maybe we don't think about quite as much. Your PDE5 inhibitors for erectile dysfunction, your Sinemet, your SGLT2 medications for diabetes, for example. Those can all drop blood pressure a little bit and could have some additive effects. Lithium. So lithium concentrations can increase on account of use of thiazide diuretics. So be really, really careful there. We're probably going to recommend alternative blood pressure therapy versus using hydrochlorothiazide. If hydrochlorothiazide is deemed absolutely necessary, we got to recognize that we're probably going to have to reduce the lithium dose and monitor levels there. NSAIDs, ACEs, ARBs, remember that those medications can be taxing on the kidney, so adding them on top of hydrochlorothiazide could potentially increase the risk for renal impairment. So again, got to use those medications wisely and obviously monitor kidney function if we're going to use them together. Topiramate can interestingly cause some additive hypokalemic effects. So again, monitoring that potassium following the addition or increase in dose of hydrochlorothiazide on top of topiramate or vice versa definitely is going to be important there. Vitamin D, calcium supplements, these can raise calcium levels, which may be what we're trying to do with these supplements. But keep in mind, hydrochlorothiazide can raise calcium as well. So depending upon the dosages and all that sort of stuff, we may need to keep an eye on calcium a little bit closer there. And then hyponatremia risk, I wanted to mention. SSRIs, carbamazepine, oxcarbamazepine, all those drugs can cause hyponatremia. Hydrochlorothiazide can have kind of an additive type effect there as well. The blood sugar issue I kind of mentioned in adverse effects, as well as the uric acid issue. So, with uric acid, obviously hydrochlorothiazide could blunt the effects of a drug like allopurinol, which we're trying to use to lower uric acid. And same thing with diabetes medications. Again, probably not clinically significant, but hydrochlorothiazide could potentially cause hyperglycemia, which opposes the benefit we're trying to get from blood sugar lowering medications. All right, well, that's going to wrap it up for today. Thank you so much for listening. Share us with your friends, colleagues. If you have students with you on rotation, definitely help grow our audience and share the Real Life Pharmacology podcast. Leave a rating, review on iTunes or wherever you're listening. That's greatly appreciated to those of you who have already done that. And of course, if you want to reach out to me, mededucation101@gmail.com, or you can track me down on LinkedIn. I'm going to sign off for today. I thank you so much for listening, and I hope you have a great rest of your day.